Thank you. Thanks for the warm introduction. I want to thank all of you folks for coming out on a school night to spend some time with us tonight to talk about, one of my favorite topics, which is low back pain. It's one of my favorite topics to try to help people with. Let me just, if I can, get a quick show of hands. How many of you either know somebody with low back pain or experiencing it yourself, have a friend or a loved one who does? Yeah, I somehow thought so. We're going to get to the prevalence of this in a little bit. By way of background, I'm the division chief for pain medicine here at Stanford. I've been here now 18 years. I did my training here originally in anesthesiology. I went on and did pain medicine fellowship, and really I practice 100% pain now. I take care of patients on average about 1 or a little more days per week in the clinic, and the other 6 days I'm in the lab, where I work with an incredible group of people where we're trying to understand and unlock the human mystery of pain, to try to understand why pain is so different from one person to another, why people respond so variably to different treatments, what happens when chronic pain goes bad and it becomes a disease in and of its own right. And we'll talk a little bit more about that. Our lab site is up here, which is snapple.stanford.edu, and then the clinic website is paincenter.stanford.edu. It's traditional these days to give one's disclosures, so you know whose pocket the speaker is in, where they're getting their money from. I'll share with you that all of my conflicts are with the National Institutes of Health. I'm trying to be more conflicted by them, but I'll share with you it's a tough time, particularly with the government shutdown right now. The other funding that comes for all of our research is through philanthropy and generous donations that people have made to our research efforts, and I'll touch on a little bit of the research that we've done that's been helped out by philanthropy. So what I'm hoping that you folks will be able to get out of tonight's discussion is the following. I want to make sure that you can appreciate the burden of low back pain, not only for the individual, but also for the families as well as for society as a whole. I want to talk a little bit about some of the basic science of low back pain. And when I mean basic is I want to give you some introductory information about the science of low back pain, and again, how it can transform into a disease in and of its own right. And then I want to talk about how we go about assessing and treating chronic low back pain. And the focus here is truly going to be on chronic low back pain, because that's the one that really causes the biggest problem for many of you and for the rest of us in society. So about 1.5 years or so ago, I was honored to be on an Institute of Medicine panel that addressed the issues of pain. And I was a co-author on the book, the report that came out of this. Our most recent dean, Phil Pizzo, Dr. Pizzo, was the chair of that committee. And we were tasked by Congress to address several things in this. We were asked to address the burden of pain in this country. And so we commissioned an econometric study that assessed how much is a problem with pain in this country, and the numbers were just simply astounding. We found that there are 100 million Americans that suffer from chronic pain. That's 37% of the U.S. adult population. That's more than diabetes, heart disease, and cancer combined. We spend $500 billion a year in taking care of patients with chronic pain. And one of the messages that we put out is that while pain is often a symptom of something else, it can become a disease in and of its own right. Much like diabetes, it starts off with high blood sugar, it moves on to what we call impaired glucose tolerance, and then it can become this disease we call diabetes. It's too low.
It's hitting your jacket.
Thank you. How are we doing now? Good. Is it coming across a little better? Perfect. So we're going to talk a little bit more about this disease of chronic low back pain, in just a moment. And one of the other little sound bites here that's often not appreciated is this issue, this conundrum of prescription opioids. We see the problem of opioids in the press just about every day. Our country is awash with prescription opioids, and it's been called by the CDC as an epidemic. It may not be aware to you, but the #1 prescribed medication in this country is Vicodin, which is hydrocodone. I don't mean the #1 prescribed pain medication. I mean the #1 prescribed medication at 131 million prescriptions. The next closest is simvastatin, way down there. It's an anti-cholesterol drug at 81 million. So we need better treatments. We need treatments that are less addictive, less problematic. When we talk about the burden, the prevalence of pain, low back pain, I usually start off by saying that, there are three givens, right? Death, taxes, and low back pain. The numbers they say are that lifetime prevalence is anywhere from about, around 80%. And, my read on it is it's really about 100%. The other 20% I think have forgotten that they had it or are lying about it. Everybody gets it. Everybody gets low back pain at some time in their life. The good news is that most of it resolves, and we'll talk more about that momentarily. We reported on this study in the Institute of Medicine report that when you look at the prevalence of this at any given time, about 28% of Americans have some degree of back pain during a 3-month period of time. It is by far the most prevalent painful condition in our society. It blows away everything else. Migraine headache is down here at 16%. It's close, but back pain really just overwhelms everything. And the problem's only getting worse, folks. It's only getting worse. A study that came out of North Carolina, where they looked at a population there in North Carolina, and they found that, over about a 14-year period, that there was almost a doubling. There was a doubling from 4% to 10%, that's more than doubling, of people with chronic low back pain. And for women of all ages and men in 45 to 54, it almost tripled in size. So we're seeing, as time goes by, an increase in this prevalence of low back pain. Some of this because of the aging population. We're all getting older, and there is a relationship with age and low back pain. Now we started off talking a little bit about some of the bad news. The good news is if you get low back pain, 80% of the time, it's going to resolve within the first month. And about the other 10% will go away during the next few months. But the bad news is there's going to be about 10% of people that are going to probably be left with some degree of chronic persistent low back pain after that initial episode. And there is higher recurrence for people who have a severe acute low back pain episode, anywhere from, some studies say 5, some say 80%. And there are some predictors, by the way, of those people who will go on to have some degree of chronic low back pain. And what we've learned is that what you bring to the injury, what you bring to that back pain episode, often has more to do with whether it becomes persistent than the severity of the injury itself. Things such as fear avoidance, pre-existing, how much fear do you have to pain up front, how much anxiety or depression, how stressed you are, what's your job dissatisfaction like, what's your prior history of low back pain. All of these play a role. And the interesting thing that we're learning also is that these numbers with low back pain, this 10% who go on to have chronic pain, that's right about the same number of people who end up with chronic pain after a surgical procedure. If you go on to have a significant surgery, about 90% of people will recover from a pain standpoint, but the 10% will go on to have chronic pain. And what we're learning is that surgery and most of these significant injuries like low back pain, they have this magic or so 10% number. A big part of what we're trying to do in our lab is to figure out what makes those 10% unique. Why are they the ones who are vulnerable to getting chronic neuropathic pain, chronic low back pain, and chronic pain from these other injuries? It's been shown that there are certain jobs that lend one, certain activities that lend oneself to developing this problem of low back pain. That those jobs that are heavily involved with lifting, twisting, bending, reaching. It is, by the way, the number one reason for those of you, who have worked or who run businesses or employ people. Number one cause of people being out of work and long-term work disability. And the interesting thing is, while chronic low back pain is only about 10% of all those who get low back pain, it accounts for 80% of the costs. So huge, huge burden on society. And we could make a major dent in our healthcare costs if we could do better with this issue of chronic low back pain. So I want to switch gears a little bit. I want to talk to you. I want to talk with you about some of the science of pain in general, to help you to understand, why pain exists, what happens with low back pain, what happens when it goes bad. So I want to start off with this guy Descartes. Descartes was the 17th century French philosopher. The guy was brilliant. Brilliant philosopher, an amazing mathematician who came up with a lot of Cartesian mathematics. Absolutely brilliant. He was a lousy pain researcher. He was incredibly bad. And I'll tell you, he screwed it up for all of us because he came up with this model, this what we call this dualistic model, where he saw this separation between mind, brain, and body, as illustrated by this small child with his foot in a fire that was pulling on, his model was that this fire pulled on a delicate string that led up to at the common sense center in the child's brain. It was the pineal gland. Descartes thought the pineal gland is what made humans uniquely human. Opening up pores in the pineal gland, ringing a bell, and causing the child to withdraw his leg. And it was a clear direct link between the stimulus and the pain, a one-to-one representation and this reflexive behavioral link. This model was all wrong. But it turns out this model has been with us for hundreds and hundreds and hundreds of years. And it was even taught in medical textbooks up through the 20th century. And many of us are still taught in medicine to believe in this dualistic model of pain. What we've since learned is that mind, brain, and body are all connected, that they're all ultimately one. I'm going to show you some of the science of that to try to convince you. Now, if we're going to talk about pain, we need to have a common language. Each of you throughout your life has been in different activities, different lines of work, and you have language that you use to talk with each other. And pain is no different. So the accepted definition for pain is that it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, the key take-home messages are the ones I highlighted. Pain is an unpleasant sensory and emotional experience. That defines pain, that experience defines pain as something that's subjective, something that we can't objectify, something that we can't easily measure. We depend upon what our patients tell us, and we have to rely on that. And it is highly variable and highly unique to each individual person. Each of you experiences pain in a different way. And I'll share with you, we run experiments all the time. If we give everyone in this room the same stimulus, the same temperature heat stimulus, each of you will report a different pain score from 0, which is no pain, to 10, which is the worst imaginable. It's very cool. I do this with the medical students each year, dipping their arm in an ice water bucket for 15 seconds, and then they whisper in our ear the pain score, and we plot it, and it runs the whole range. And I think it drives home the point to the medical students, our future physicians, that when a person is complaining of 10 out of 10 pain, and it doesn't look like they're having much in the way of injury, that we shouldn't provide any value judgments on them, that their experience of pain might be much different from theirs. All right, let's talk a little bit about some of the background, some of the science of pain, if you will. So I use this slide here which illustrates where things all start. Pain all starts often with a stimulus. And in this case, it could be a burn in the hand or an injection of something called capsaicin, the stuff that makes red hot chili peppers hot underneath the skin, causes a burning sensation. What it does is it activates primary nociceptors. Now, primary nociceptors, it's a Greek term. Primary nociceptors serve a singular purpose. They serve as a transducer. And if you are engineers, you know what a transducer is. It serves to convert one form of energy into another form of energy. And so this microphone is a transducer. It converts sound energy. It converts sound energy into electrical energy. These transducers, what they do is they convert mechanical energy, they convert temperature, they convert chemical energy in the form of pH changes into an electrochemical action potential that's transmitted up 2 different nerve fiber types. And these nerve fiber types, one is called A delta and the other is called C fibers. Now the A delta fibers, they've got a little bit of insulation around them, and so they transduce really, really fast. They transmit very quickly, about 10 meters a second. The C fibers, on the other hand, don't have any insulation and they're kind of pokey, they're slow. They are transmitting at about 1 meter a second. So I want you to think back to the last time you hit your thumb with a hammer, or you stepped on a tack, a sharp tack, or you rolled your ankle stepping off the curb. Let's go back to that thumb. Hit your thumb with a hammer. What happened? You get this sharp jolt of pain that goes right to your brain, right? Those are your A delta fibers firing off at 10 meters a second, getting up to your brain in less than 100 milliseconds, really fast. And then what happens? You have just enough time to think to yourself, oh damn, this is really going to hurt, right? This is really going to hurt. There's a delay, and then you feel this hot, burning, flooding sensation come over your thumb. And why that delay? The delay is because the C fibers, which transmit at about 1 meter a second, turns out that my thumb is about 1 meter to 1.5 meters away from my brain. And it takes that long, about 1 second to 1.5 seconds, for the signals to get from my thumb to my brain. And the sensations that are transmitted here by my thumb, out here by these C fibers, entirely different from the A delta fibers. It's hot, it's burning, it's flooding, it's kind of like taking over your entire thumb. And that's the way these two different nerve fibers work. They transmit different types of sensations. Now, the key here is that what goes on out here, this isn't pain, folks, or in your back. This is a key take-home message. This isn't pain. It's not actually pain until these signals come up through the spinal cord in your back and then head up to the brain, where these signals are sent to different regions of your brain, where ultimately pain is processed and perceived. It becomes this experience of pain. What goes on out here is something we call nociception. Nociception, which is just a little electrical signals that occur during tissue damage and injury. So these signals head up to the brain, and they serve different functions, different aspects of pain that I'll talk about. But the story wouldn't be complete if we didn't have some way of controlling all these signals that are bombarding us on a regular basis. And so we've developed these inhibitory pathways that turn down the signals. These are the blue pathways that come down from our brain, down into the spinal cord, and it forms a closed-loop feedback system. The purpose of this is to filter out unnecessary information, information that's not important. So you're not paying attention to the feel of the clothing on your back until I just mention it. That's these inhibitory systems that are telling you don't pay attention to that information. It's just not important. Now, as I mentioned, and I'll come back to the inhibitory system in just a moment, pain is not nociception. This is what's going on out in your body, in your back, is nociception. There is not a one-to-one link between this. For the same amount of nociception that a person has, the amount of pain is ultimately a reflection of this information that is then amplified by all of these other aspects. And I say amplified. My PhD is in electrical engineering. I think in circuits, and I think in wiring and amplifiers, and that's the way I talk. And so you've got all these little amplifiers and circuits in your brain that take this information from our body and either turn it up or turn it down. And there are amplifiers here that are based on your cognition, which is your beliefs about pain. And is the pain threatening? Is it not threatening to you? Whether you're distracted from pain or you're attending to it. If you think back to times when you've been distracted away from pain, you don't feel it. And that works beautifully for many people. Beliefs in placebo. Placebo is a big player these days in pain. Mood, depression, anxiety. This one here I'm going to talk about a little bit later, catastrophizing. Probably the biggest predictor of whether someone will go on to have worse pain and worse severity pain. Catastrophizing has got 3 parts to it. It's got negative amplification of pain. Oh, this is terrible. This is just the worst thing ever. It's got rumination of pain. Rumination is circular thoughts. This is never going to get better. This is just going to go on and on. My life is terrible. It's never going to get any better. Oh my God, this is the worst. It's those circular thoughts. And the third part is it's a loss of control, a sense of that you have no control over your pain. Number one predictor of whether you're going to do worse with chronic pain. And then there's individual differences. It's the genes that our parents handed down to us that we had no choice, which set us up, if you will, with having a certain sensitivity to pain and maybe a certain propensity to develop chronic pain. And then early life experiences. It turns out we're learning more and more that the experiences that we had as kids and that our children are having ultimately shape later on their likelihood of developing chronic pain and how severe that would be. I told you there's these little amplifiers in the brain. What we've learned and what I do for a living is I do a lot of brain imaging work. I spend time using fancy magnets, MRI systems, and putting people in them, and I poke them with a sharp stick or a hot probe. We don't harm people. And we pay the Stanford students here who subject themselves to this a lot of money to go through this. But we've learned from this some wonderful, wonderful things about the different brain systems and the role that they play. And we've learned that different brain systems here play a role in different aspects of pain. This area, the somatosensory cortex, involves with kind of determining some of the location aspects, where in your body the pain is. This anterior cingulate cortex here, some of the emotional aspects of pain, how much I don't like the pain. The prefrontal cortex, more of our thought related to pain. What is it going to take for me to get away from the pain? This amygdala here, some of the fear-related aspects of pain. These are some of the things we've learned. And as I said, I do neuroimaging for a living, so I have to have at least one rotating brain in my slide kit. And this is the rotating brain tonight. So this is your limbic forebrain system right here that has now just been exposed. This is where your basic emotions are processed and perceived. This is your love, your fear, your hate, your anxiety, your tension, your anger, your depression. All of that in this area. And what we've learned is that these systems in the brain that process these emotions are the same systems that are involved with processing our perception of pain. And so if you ever find that you've had a fight with your spouse or a friend or your boss is coming down on you, you're feeling stressed and you've got a deadline, and you're noting that your back pain is getting worse and it's acting up, or you're getting a headache, well, guess what, folks? You're winding up these circuits here, and it's winding up the same circuits in the brain that are involved with pain, that they completely and often totally overlap with each other. So I mentioned to you before about this idea of nociception, information coming up to the brain, and then also the inhibitory systems acting like a closed loop feedback coming down. And we ultimately have this yin and yang, this homeostatic balance that we all have, so that if you don't have pain and you're sitting there, relaxing, you're in a nice balance. But it turns out if there's too much excitation, and these are some of the neurotransmitters, some of the chemical transmitters that are used to transmit that signal, or, and this is where a lot of the research is going, we're learning that you can get pain from the same amount of normal excitation, but too little inhibition. If your filtering system isn't working right, for the same normal amount of input coming in, you can still have pain, and your body perceives it as being painful. There's another phenomenon that's worth mentioning, this concept of central sensitization. This is what happens when pain goes bad. So let's go back to the hand, and let's imagine you cut your hand with a knife, and what happens? Sharp jolt of pain goes right to the brain, right? A second later, oh damn, really going to hurt, hot burning flooding sensation comes over your hand. Then about an hour or so later, you find that your hand is getting swollen, little redness, it's sore over a larger area. And we call that phenomenon is called primary hyperalgesia. What happens is you get a lot of release of inflammation. And that inflammation winds up those nociceptors. It amplifies them out in the skin. Then you go to bed, you wake up the next day, and doesn't your whole hand feel stiff, aching, and sore? Right? Think about the last time you twisted your ankle. And sharp jolt of pain, you got some swelling, but you went to bed, you get up the next day, doesn't the whole foot and the lower part of your leg feel stiff and aching? Well, it turns out if you sample the tissue outside of where it was injured, you'll find that it's totally normal, stone cold normal, but it hurts, it aches. Why? The reason it aches, the reason it's painful is that overnight, your nervous system has rewired. Your nervous system has rewired and it's expanded. Your brain has now expanded the areas around that injury that it perceives as painful. Now, why would your brain do that? It does it because it serves a survival message. Back in the cave people days, when we were fighting the woolly mammoth and the saber-toothed tiger, if we got injured, it was in our best interest to do what? To go sit in a cave and let nature run its course and let it heal up. Because if we went out to fight the saber-toothed tiger or the woolly mammoth, when we had an injury, what would happen? We would get eaten. And we didn't get to pass our genes on down to the next generation. So it serves a great signal to us to rest and heal up. And what happens is we rest and we heal up, and the central sensitization goes down to normal. We heal up, we go out, and we can take on the woolly mammoth. What we're learning is that in some people, we're still trying to figure this out, in some people, those neural switches don't turn off, that they stay expanded, and they'll grow even larger, and they'll take over a larger part of your body. And in part, we believe that this is responsible for conditions such as, have you heard of fibromyalgia? This affects 4 to 6 million Americans, most of them women. fibromyalgia, temporomandibular disorder with jaw pain, some headaches also in this phenomenon. We think also that low back pain plays a role here. We know that low back pain doesn't just affect the back, that it takes on the whole person. And as a consequence of that, we see a huge amount of emotional distress. Patients get anxious, they get depressed, they get angry. Anger is often not well appreciated, but it is highly prevalent in people who have chronic low back pain and other chronic pain conditions. Their sleep all gets out of whack. They have this existential suffering. We have some chronic pain conditions where people, they'd almost rather die just to get away from the pain. Now, they're not going to necessarily actively take their lives. Some people have, but it's just they feel that they're hopeless. They have no choice. And overall, it leads to a terrible decrease in quality of life. I've told you that there's a lot of these circuits in the brain that are responsible for this individual experience of pain, amplifying it, and even for amping up or the central sensitization. But what is the effect of chronic pain on all this? Well, what we learned is the following. We've done a number of neuroimaging studies. This is one we just published related to chronic low back pain recently. And what we learned is the following, is that if you look at the structure of the brain, the gray matter of the brain, and compare it against healthy matched controls, that chronic pain is associated with real abnormalities in brain structure and even function. And some of these abnormalities, for instance, are some of the frontal areas of the brain. These frontal areas of the brain are involved with things like executive functioning and working memory. Working memory is keeping pieces of information in mind. If I give you a phone number, a 7-digit phone number, and I tell you to keep that information in mind or even to spit it back to me. Executive functioning is making complex decisions. And we're finding that these circuits are getting impaired in the brain in people with chronic low back pain. So maybe we used to think that sometimes when people have chronic pain and they don't seem to be as cognitively fast and they seem to have memory impairments, we thought it was due to maybe they were depressed or maybe it's because they were on medications. We're now learning that it may be because of the chronic pain itself fundamentally changing these brain circuits. Now, I was often asked, they'd say, Dr. Mackey, is it permanent? Is it permanent? Am I always going to have these brain changes? Is it ever going to get any better? And I didn't know. We didn't know the answer to that in the past. But we now have a better feel for it. This is a really complex slide. It was an elegant study that was done by David Semenowitz. Came out about a couple years ago. And I'm going to take you through some of this. What they did is they took 18 people with chronic low back pain. And they did structural brain imaging on them. And then they also did a cognitive task. This is a working memory task to determine how well they can perform with that working memory, with keeping pieces of information in mind. And what they found is these patients, these people with low back pain, had abnormalities in an area of the dorsolateral prefrontal cortex, area right over here involved with working memory, executive functioning. They then underwent treatment. Using either, they had surgery, they had some procedures done, their pain resolved, they imaged them again. And what they found is that there was normalization of that area, and there was significant improvement on that working memory task, and there was increase in brain function in that area involved with working memory. So it suggests, the good news is it suggests, we still need to do more work, that these changes aren't permanent, that with appropriate treatment, we can regain function, and it will also help normalize some of the structure in the brain. Preliminary, but very, very promising. Okay, so I want now to talk and switch gears towards the more clinical situation. How do we go about assessing somebody with chronic pain, and what do we do to treat them? I'm going to focus on what we do at the Stanford Pain Management Center, but this would also apply to many major tertiary referral centers. So the most critical thing when we see a person with chronic low back pain is to make sure we get a good initial preliminary assessment. That means doing a detailed history and physical examination. 90% of the information that we get as physicians is from the history. Everything else, that other 10%, the physical exam, all the tests we order, it's predominantly to confirm or rule out our clinical suspicion. So we should be asking you a lot of questions about your low back pain. We want to make sure we do a detailed physical includes a detailed neurologic examination. We want to try to identify any of those social or psychological factors that may be playing a role. Remember those amplifiers I showed you before? We want to identify those because there's some things we can do to help with that. And if indicated, and only if indicated, then we order lab tests. That might be blood tests, which I didn't put up there. It might be neuroimaging tests. It might be doing some diagnostic nerve blocks to see if we can selectively numb up nerves that may be contributing to pain. When we talk about low back pain, it's also helpful to break it down into a couple different categories. And we think about low back pain in the context of whether is it axial low back pain, which means that it tends to be confined around this axial spine portion, or is it radicular? Radicular means that it's due to compression of a nerve root or irritation of a nerve root coming out, and you get pain that radiates down your leg and much like a line. The interesting thing about axial pain is that while it can refer, I often get patients coming in saying, yeah, doc, I got sciatica, I got pain that's going down my leg. It often, what you will find is that with axial pain, it doesn't go below the knees. It usually stays above the knees, and that's one of the helpful determinants for us. Whereas with radicular pain, nerve root pain, it often goes down the leg and oftentimes into the foot. So we use that information to tease some of this apart. We also note anatomically that there's different structures that contribute to different types of pain. And so this is a section here of the spine, the lower part of your lumbar spine, and we know that the areas such as the vertebral bodies can get irritated or compressed and have fractures, and that can contribute to axial pain. The discs themselves can have abnormalities and have ingrowth of some of those C fibers, leading to axial pain. And then the ligaments and the facet joints also can get irritated, contributing to axial pain. This is a slice right through the spine here. This is your spinal cord. And what happens is that the disc can sometimes protrude and compress on that spinal cord or on the nerve roots, leading to what we call radicular pain. So this is what we do in our diagnostic workup to try to tease this apart. Now the key message here, by the way, is that despite what I've said, the vast majority of low back pain is what we refer to as this nonspecific mechanical low back pain, and it comes with a large number of different terms. Some say just call it mechanical low back pain, some call it idiopathic. I'm not really fond of that term at all, but it's this general mechanical low back pain, and it's only a small portion of low back pain that's due to some sinister cause. Some sinister cause such as cancer, which is less than 1%. Cauda equina involves compressing the nerve roots that come down from your spinal cord. You often have bowel or bladder loss of control and you can't walk. That's a serious event, much less than 1%. We have a few percentile that are due to herniated disc or spinal stenosis. So the vast majority, and it's usually over 90%, is this nonspecific mechanical low back pain, oftentimes where we can't specifically identify a structure that is at fault. With this version, this 85 to 90 or more percent, it's usually conservative therapy, and it's not much further workup. If we have a sense of radicular pain, a pain radiating down the leg, particularly if there's any weakness in your leg, we'll often get some neuroimaging studies to be able to tease that apart. And if you have these other sinister causes, compression fracture, ankylosing spondylitis, cancer, cauda equina, we'll go and pursue that and try to identify it, getting some additional lab and neuroimaging workups. One of the first things that we do also with back pain is we try to rule out this thing we call red flags. Now, red flags are these sinister causes of back pain that we want to get on immediately. We don't want to let these go by. Because they can be serious. And so if somebody comes in complaining of nighttime pain, fever, weight loss, a history of cancer, or if they tend to be on extremes of age, particularly the elderly, and it's a first onset of low back pain and somebody's 70 years old, and they've never had low back pain before, and they're accompanied by these other things, I'm going to do a pretty aggressive workup to rule out cancer. If somebody has had trauma, and this is typically at the other extreme. These are the two extremes. These are the very young. These are the teenagers. and also the elderly, the teenagers are often involved with heavy sports, and they might get a compression fracture. The elderly, because of bone density loss, may get a compression fracture. We're going to get imaging studies to rule out or rule in a compression fracture. Those causes, by the way, all of this here, only a few percentile of low back pain, only a few percentile. Small numbers, but we don't want to miss them. One of the questions I get all the time is, Doc, do I need an MRI? Do I need an MRI? And this is a series of studies that I think is fascinating. What they did in these series of studies is they did MRIs of people who have no pain. They've got no low back pain at all. And what they found is that for people who have no low back pain, a large percentage of them have herniated discs or bulging discs. And an even larger percentage have degenerative disc. Have you guys all heard of this degenerative disc disease? You have all heard of this one? Yeah. You know what? If you're over the age of 30 or 40, we've all got it. I have no doubt that I've got it. I don't have back pain. It is a neuroimaging, it's a radiology term that they call anything that's got a loss of fluid content and sponginess in the disc. And I wish we had a better term for it. Let me ask you, if you ever go to the dermatologist or you go to your primary care doctor and you're older and maybe you've got a few wrinkles, do they ever say that you've got degenerative skin disease because you've got a few wrinkles? No, it's a normal process of getting older. It happens to all of us. It's the same thing with this degenerative disc disease. It's really only meaningful if we can correlate it, if we can show some correlation, some causation with your pain itself. And so it's one of the things that in society is that we overuse MRIs, and there's a number of calls out from the primary care on through subspecialists that we shouldn't be getting MRIs if you've got straightforward axial back pain. That only to get it under certain circumstances. So let's move on and let's talk about now some of the therapeutic approaches. So you got to have the right tools for the job or you're going to get awfully frustrated. So, hot oil, we need hot oil. Forget the water balloons. We need the right tools for the job here. And what are the tools? Well, I break them down into 6 major categories. This is how I break down our therapies at the Stanford Pain Management Center. First and foremost is personal management. I've got the 5 Ps and then the C. I'm still trying to find some way of putting a P in complementary and alternative medicine. But you've got personal management or self-management. You've got pharmacologic management. You've got physical and occupational therapy. You've got procedures. You've got psychological and behavioral management, and then the complementary alternative. And as I'm going to show you, I'm going to go through each of these briefly. I'm going to show you it's really best in particularly complex situations to do this as one coordinated multidisciplinary approach. And that's actually what this article from Time magazine showed. Typically when you open up the press, they're showing you the latest and greatest single treatment for pain. This particular article in Time showed that multidisciplinary approaches really is where the money is and where the best bang for the buck. Okay. When you look at the American College of Physician recommendations, they noted also that the vast majority of low back pain goes away on its own. But during this initial 4 weeks, the recommendation across the board is self-education. Learn about it, understand your back pain, understand it, get educated, and remain active. Use some heat on the area, get some books. The back book is one example of that. There's many of them out there. If after 4 weeks of self-care and there's no improvement, then consider some medication, some NSAIDs, ibuprofen, naproxen. Go see your primary care physician. They're handling the vast majority of it. Most pain is taken care of in the home. Those 100 million Americans, the vast majority are managing it on their own. My father used to play semi-pro sports, got really beaten up when he was much younger, suffers from a lot of pain, refuses to see the doctor, just kind of sucks it up. He won't even talk to me about it. I'm the expert, so he gets by with a lot of self-management. The pharmacologic, the medication approaches to this, here's the key message. In pain, we steal from everybody. We steal from everybody. We take from the psychiatrists their antidepressants, the neurologists their anti-seizure medications, the cardiologists their anti-arrhythmic medications. And here's the interesting thing. These are mostly off-label uses of medications. We find that they often work much better for pain than for the original indication that the FDA approved them for. That's the interesting thing. There are anti-seizure medications such as gabapentin. It's a lousy seizure drug. It's a great pain medication. And there's other examples. You'll hear one of the key things, we'll often prescribe classes from the antidepressants, and people say, Doc, I'm not depressed. I don't want to be in an antidepressant. I don't want you thinking I'm crazy. And the message is, I know you're not crazy. You're not that depression has nothing to do with this. These medications work on different brain circuits up here. They work on different and the same brain circuits that are related to pain. And they can do a great job in reducing pain through working on those circuits. When I think about medications that we prescribe for pain, I think about where they target things. Do they target nociception out in the periphery? This is where I might put a nerve block or a local anesthetic block or something such as a lidoderm. I don't know if you've ever tried those lidocaine patches for pain. They work out in the periphery. There are medications that we prescribe that are sodium channel blockers. What they do is they reduce the firing. Sometimes you get increased noise along the nerves that ultimately becomes pain, and it calms down the nerves. It's like turning down the noise on nerve pain. We have medications that work in the spinal cord that have all sorts of different actions. And then up here in the brain, as well as we also have medications that crank up that descending inhibition, that crank up the filtering and help it work better. And this is a blow-up of this with just some of the medications that we use for pain. And you're not supposed to recognize these. That's okay. It's a huge number. I broke all the PowerPoint rules. I know that. And don't turn me into the PowerPoint police. The point of this is we have more than 20 or 30 or more different types of medications that work at different places related to pain. And so we have now a lot of tools in our toolbox. When I got into this in the late 90s, we only had a few. Now we have a lot more. So I want to move on and talk now a little bit more about some of the psychological and behavioral approaches for pain. You remember, well, I'll get to that. One of the key things is this stress-pain cycle. Stress begats pain, pain begats stress, and it's all shaped by many of these other factors. What's going on in your life and your work, your coping resources, the personality predispositions, all of that can lead to a buildup and a vicious cycle between pain and stress. And you remember these amplifiers I talked about. These amplifiers are all in your brain. And so what we've learned throughout decades is that our pain cycle, let me show this slide here, this little clip, which might help illustrate, some of this role of the brain and its perception in pain.
I'm a Vulcan doctor. Pain is a thing of the mind. The mind can be controlled.
You're only half Vulcan. What about the human half?
It is proving to be an inconvenience.
Okay, so let's talk about that inconvenient human half here for a second. So what we've learned, pain is a thing of the mind. The mind can be controlled. So very, very true. And what we've learned is that by working closely with our pain psychologists, people who are trained specifically to deal with pain, they can help people to develop skills. It's a different type of psychologist than what you're used to seeing on TV or in the movies. Somebody lying on a couch for 15 years talking about, the relationship with their mother. That's not what this is about. This is teaching you skills. It's teaching you how to better cope with pain, how to better rethink your pain, how to understand how you respond to pain and how that response to it may not be helping you. And we use things such as, with fancy terms like cognitive behavioral therapy, mindfulness-based stress reduction, acceptance and commitment therapies. And this stuff works. It doesn't work for everyone. It won't cure your pain, but it often can knock it down quite a bit. And more importantly, the most important thing that I feel with these approaches is it can often give you back control of your life. And that's what people really want, is control of their life. We do a lot of procedures. A lot of procedures related to pain, everything from simple trigger point injections, this is putting it into spasming muscles, local anesthetics and a needle, to different type of nerve blocks, epidural steroid injections, medial branch blocks, all the way up to radio frequency. We burn the nerves that are responsible for transmitting nociception. We can put in drug delivery systems that drip in medication into the fluid surrounding your spinal cord. And we even have spinal cord stimulators that apply electricity to the back part of the spinal cord. It can cause, if you will, it's like a distraction, if you will, in the spine, so that it substitutes that buzzing sensation for pain. And I'm just going to touch on just a couple of these because it would be a whole lecture to talk about all of them. The facet joints are often thought of as a source of nociception that leads to pain. And I use that term nociception because it's not pain here, it's nociception. And these facet joints, they are actual joints in our spine, and it allows us to bend, to twist, to rotate. And if we didn't have facet joints, we would all walk around as if we had a pole stuck up our butt. We would be all walking around like this without facet joints. So it is what has allowed us to evolve to have a flexible spine. But those joints can get arthritic, they can get inflamed. And sometimes it's helpful to go put a little local anesthetic and steroid over that inflammation. It helps calm it down. And use it for both diagnostic purposes, and some people can get some long-term benefit. And we can also go and do a little bit of a rhizotomy here and burn that nerve. And it will take care of that nociception and ultimately the pain for sometimes periods of 3 months, 6 months, 9 months. And you know, the data on it is decent. It's variable, but it's decent, and I've had a number of people that get some great responses and others who don't get much response at all. And the key is to try to figure out for whom it will work. Then there's epidural steroid injections. You guys have probably heard of these. These really have the biggest role for more of that radicular pain, the pain that's radiating down the leg from a nerve root irritation. The data on this is really that it helps during the short period of time. Not been able to show long-term benefits to epidural steroid injections, but it may help facilitate getting you into a rehabilitative course. And I think that's the key message with all of these procedures, is that the vast majority are not curative alone, but that they help you to engage into physical rehab, to get stronger, to ultimately address the core problems that got you into this situation. And then there's complementary and alternative medicine approaches. These are things such as acupuncture, nutraceuticals, or also these are the nutritional supplements you buy at the vitamin shop. And then also I put mindfulness-based stress reduction. It could be under this category, or it could be under psychological therapies. When we look at acupuncture, the data on this is generally good, but sometimes mixed depending upon the study you find. It shows that there is some short-term benefits. There's not good long-term studies to be able to draw conclusions yet. I have patients, some of the patients get incredibly better, and I've got other patients that don't get better at all. When people say, you know, Dr. Mack, what do you think about it? Do you think I should try it? My response is usually that, you know, if you can tolerate the wallet biopsy, because this is usually out of pocket. Your insurance company often doesn't cover it. If you can tolerate the wallet biopsy and it's helping you to improve your physical function and quality of life, then it's probably worthwhile trying and maybe even continuing for a little while. But if you're just getting it and you feel better during the period of time you're getting it, but then your back pain comes right back when you're walking out in the parking lot, there's probably not point in continuing to repeat that. Okay. I want to talk briefly, I want to move into low back pain and movement as I'm closing things out. One of the things that also got us into trouble, I told you about Descartes, brilliant philosopher, lousy pain physician and pain researcher. We're also left for decades with this concept of the rest theory. This idea that if you got an injury, it was best truly just to lie there and sit there and don't do anything and let nature take its course. And it turns out that, you know, this came about through a lot of the tuberculosis patients where we put them into conservatoriums and we had them rest to help regain their strength. And we then started applying this model to other chronic conditions, including chronic low back pain. So we tell people with low back pain, oh, go lie in bed for 4 to 6 weeks and get off your back. Turns out now it is absolutely the worst thing that you could ever be told, is to go lie in bed for that period of time. Because what happens is the same thing that happens with the astronauts that go into outer space, is that your muscles get weak. Unless they're being used, unless you've got gravity on them, your muscles get weak and then they shrink, they tend to contract, and when you then start to move around, they go into spasm and you get more pain. And you get into an ever worsening spiral of disuse and disability. So we get involved with things such as physical therapy. We rely heavily, and it's one of the major treatments that we use for chronic low back pain and chronic pain in general. We want patients to engage in weight loss because with chronic pain, people often put on weight that can add additional stress to their spine. We want to educate them about their body, help them understand what works and what doesn't work, what's safe, what's not safe for them to do. We want to do specific goal-oriented paced activities. What do I mean by that? What we find with people with chronic pain is when they have a good day, they often go out like gangbusters. And then, I don't know if you've ever noticed this, and then what you do is you pay for it for the next 2, 3, 5 days. And you get into this roller coaster ride. We use muscle group strengthening here, and then also sometimes some modalities such as transcutaneous electrical neurostimulation, which are, it's electrical pads that we put on the back that cause a buzzing sensation. So at this moment, I want to take a moment, and it gives me great pleasure to introduce, our lead physical therapist. This is Dr. Nick Karayanis. And Nick has a clinical degree in physical therapy, and he also has a PhD in research physiotherapy. So this guy's a hardcore physical therapist, both on the clinical side as well as the research side, and he has a particular focus and interest in low back pain. And so, Dr. Karayanis, why don't you come on up? He is going to take a few minutes with you and talk with you a little bit about some of the movement, some of the exercises, and some of the benefits of what his profession can offer.
Dr. Mackey. Can y'all hear me okay? I don't have a mic, but I'm using the boom here. Sound okay?
A
A little louder? Better?
Yeah.
Okay. So we know with exercise and with low back pain exercise in particular that one approach, the one-size-fits-all approach, is less effective than an individualized plan tailored to your specific symptoms and your movement impairments. And we also know that one exercise approach is not any better than another approach. And that's sort of the rationale for needing to explore multiple modes of movement in order to determine which approach, which exercise regime you're going to best respond to. And as an example, some of us may respond with forward bending. You might get relief with forward bending. Others may respond with backward bending movements. And still others may respond to keeping the trunk in mostly kind of a neutral alignment and learning to teach their muscles or trunk muscles, limb muscles to activate a little bit more efficiently together. And in addition to a specific exercise regime, it's also suggested that you augment that with some form of aerobic activity. And the general guidelines with that are to perform that at a frequency of about 3 to 5 times a week, a duration of around 150 minutes per week, and an intensity of about 55% of your predicted maximum heart rate. So how do we go about determining which exercise approach is best? Well, I would suggest sort of approaching this as a sort of a behavioral experiment. And so performing a little bit of a functional scan of some fundamental lower back movements, which I'll review, and then gauging that to see how, before and after your exercise, if your symptoms feel better, worse, or same, and if your movement quality also feels better, worse, or same. I think that's, yeah. So some examples of a functional scan. You can begin with the forward bending of the lower back, a backward bending of the lower back, and then just some lateral hip gliding, or any other specific movements that predict your, consistently produce your back pain. And using that as a gauge or a litmus test. Those are usually pretty good litmus tests to go back to. And so what I want to do is, what I would suggest doing is starting with some standing, and those in the back may need to stand up or maybe watch the video later to see me demonstrate some poses lying down. But I would suggest starting this in standing and just getting some sense of your postural awareness. And, for example, lightly lifting your tailbone up towards the ceiling, feeling your lower back muscles activate, gently dropping your tailbone down to the floor to feel that lower back curve flatten and your lower abdominal muscles gently activate. And just kind of playing around between, those two extreme ranges to get a sense of what your neutral range is. In regards to dosing, what I would suggest doing as I go through these movements is to consider, doing these movements sort of rhythmically, 10 breath cycles, moving into and out of the postures, and drawing awareness with both your mind and your breath to that particular part of the body that you're moving. In terms of further challenging your trunk in terms of your endurance and flexibility, I would also suggest maybe progressing to doing some sustained poses for 10 breaths. Okay? So moving back to kind of the postural awareness and standing, what you can start to do is perhaps progress to some waiter's bow posing, where you're trying to keep your back in a little bit of a neutral alignment and teaching your trunk muscles and hip muscles to coordinate in kind of an effective manner. Early forward bending is oftentimes problematic for low back pain patients. That's a nice sort of retraining exercise for your brain and your muscles. You can progress to standing, doing some gentle squatting, maybe adding a little bit of a Tai Chi element to relax your body and prepare your low back, warm up your lower back, and also do some gentle strengthening of your hip and thigh muscles. You can also kind of progress that into some modified forward lunging, which is a little bit more challenging for your balance and your trunk, but also is also a nice flexibility exercise for the hip flexors that can often become stiff with chronic low back pain. Okay? And then progressing to some lying down poses. Just going to roll out the mat here. Now what I'm going to do is just kind of, again, show you some elements of, again, your exercise should contain some element of strengthening as well as flexibility and coordination. And so some poses you can explore in lying down would be practicing some windshield wiper rotations with your knees. Again, the purpose or aim of this is to just kind of coordinate your hips and your lower back motion and lightly engage your trunk muscles. You can also do some self-mobilization techniques or some stretching of your hamstrings by grabbing your hamstrings and using your hands to give yourself some gentle manual pressure in between your muscle bellies as you actively engage your knee and stretch the muscle. You can also add a little bit of a neural gliding component by taking your toes and gently pulling them towards your head. And then you can use similar sort of approach with the buttock muscles, the gluteal and piriformis muscles, using a tennis ball or a lacrosse ball or whatever you have to just kind of bring in some blood flow to the muscles and release some desensitized tissues, and just either with some sustained pressure, some off and on oscillating pressures with the knee, or maybe even progressing that to a little deeper pressure when you're sitting kind of in a long sitting pose. Okay? Then you can follow that after you've done that for a few breaths with a little figure 4 pose to kind of stretch those muscles that can become stiff. Okay? And then I'm going to show you some poses you can explore lying on your belly. Starting with just some simple heel to buttock stretches of the front thighs, and also just, again, teaching your trunk muscles to coordinate with your hip muscles. Oftentimes the lower back will accentuate that curve, and you might need to stiffen your trunk muscles to reduce your symptoms and retrain your movement. Something a little bit more challenging for the lower back in terms of motor control would be just doing some gentle rotations, again, some windshield wipers left and right. Trying to initiate that movement early with your hips, and then allowing your lower back to gently move at the end of that range. You can also experiment with some light trunk extensor activation by getting your arms at your side and just gently lifting your chest up, again with your breath, perhaps in a gentle breath in, breath out sort of sequence. Maybe adding some further challenge by practicing some prolonged holds. And another approach that you might explore is just some direction-specific spinal movements such as extension, which is often stiff on a lot of us. And so just doing some gentle press-ups, again with the breath, to your tolerance, your tissue tolerance. Or approaching that in a different manner, starting on the hands and knees. and dropping down into that posture, again with the breath, moving into and out of it, or staying in that pose. And then lastly, you can perform a few things in 4-point kneeling. Again, trying to get a sense of what your neutral alignment is with your back, doing some light pelvic rotations, feeling that curve in your lower back, and then progressing to some gentle forward and backward rocking. Again, just to train coordination between your back and hips, which can oftentimes become impaired with chronic and persistent pain. And it's a nice stretch of the hip tissues and hip joints. Next, you can maybe explore some trunk strengthening and coordination with a little bird dog pose, with lifting the arm and leg up, feeling that co-contraction of your trunk muscles and coordinating your hip muscles with that movement. And then lastly, you can allow your lower back to flex. This is sometimes called child pose in yoga. And just breathing gently into your lower back muscles to kind of facilitate a little bit of a relaxation response. Okay, so now that was a wide variety of things that I just went over. But have fun enjoying exploring those poses. And again, kind of go back to that functional scan, bending forward, backwards. Get a sense of if your movement quality and symptoms improve as you explore these. And so with that, I'll hand it back to Dr. Mackey.
So again, Dr. Carianos, wonderful job. Great demonstration. He'll be around to address any questions that you have afterwards. In the meantime, I'm going to wrap everything up here and just talk about, particularly in complex cases, but even in not so complex cases, I think the data is pretty clear that of those 5 P's and the C, the personal management, the pharmacological, the psychological, the physical and occupational, the procedural, and the complementary alternative medicine approaches, that we get the best benefit when they're combined in a coordinated, multidisciplinary manner. Study after study, and even situations like this where they've combined studies, show that that's where the best outcomes are to be found. And let me close out by talking just very briefly about what we do at the Stanford Pain Management Center. We are a major tertiary and quaternary referral center. We take care of all sorts of chronic pain conditions. I usually tell people if it hurts and it's impacting your quality of life, we deal with it. Back pain, neck pain, headaches, abdominal pain, neuropathic pain, you name it. We have over 21 clinical pain faculty, all boarded in pain medicine, coming from all walks of life. Everybody working together in one co-located center, also providing, as we've already alluded to, physical therapy, nutrition, biofeedback. And we have a very strong connection, which we've worked hard over the years to maintain between the clinical mission and the research, so that when we have new research discoveries, we get those put into the clinic as soon as possible. A little shout out with one particular research study that we're going to start recruiting for very soon. This is a wonderful study that was funded by the National Center for Complementary and Alternative Medicine, or NCAM. And they gave us a program project grant to study the effects of 4 mind-body therapies on chronic low back pain. We're going to be focusing on acupuncture, mindfulness-based stress reduction, cognitive behavioral therapy, and something that we do called real-time fMRI neurofeedback, which is kind of you're controlling your own brain in real time. And what we're trying to do is understand the mechanisms of why these treatments work, and then from whom do they work, if we can figure out predictors of who's more likely for this to work than somebody else. And so we'll be recruiting for that, we hope, starting in the new year is what our plan is, and we need to get about 400 people. So with that, let me close out and say I hope that over the course of this hour, been able to share with you just what an incredible, astounding burden low back pain has on the person, their families, and on society in general. That while most of low back pain goes away, about 10% can go on to become persistent, can become chronic, and that when it becomes chronic, it can take on characteristics. It's much like a disease in and of its own right. That it's very important when you go get assessed that they first rule out these red flags. It's only a few percentage of the low back pain, and what we have left over is often this mechanical low back pain that is often treated very conservatively, particularly during the first 4 weeks of a low back pain episode, and even conservative afterwards. And then usually at that point, go in and see your primary care doctor. You may need referral to a specialist after that. One of the messages you've heard from me and also from Dr. Karianis is keep moving. Keep moving. Don't give in to just lying in bed for days and weeks on end. I already mentioned if the pain persists, go seek appropriate subspecialty care. And as I mentioned, particularly for the complex cases, multidisciplinary care provides the best benefit. So again, I appreciate everyone coming out on a school night. It's been a pleasure to spend this time with you. I'm happy to answer questions that you may have. Why don't we open it up to you? And thank you again. I saw your hand go up real fast in the back.
Yeah, I have a question about the acupuncture. Maybe I have two parts of the question. I don't know how does acupuncture work, what do you think, why it works.
Yeah.
The other thing is the Chinese medicine says the pain is caused by the blockage of the body. So what do you think about that?
Yeah, so the question is, it's a twofold question. One is, how does acupuncture actually work? And then the question also is about Chinese medicine, the idea that pain is actually a blockage in the body. So first of all, those are somewhat linked, if you will. The Chinese model, the Chinese model of acupuncture involves alterations in this flow of qi in the body. From a Western scientific standpoint, we haven't been able to quite figure out what acupuncture is actually doing. What we do know is it is modifying some peripheral neurotransmitters, and one in particular, it's modifying something called adenosine that has analgesic effect. We're also learning that acupuncture has direct effects on the brain. And that's part of what we're trying to figure out in more detail in the study that we have. And then it turns out the Harvard group, who got the other one of these program project grants, is devoting entire to brain imaging and acupuncture. I'll share with you, I don't have a clear answer on how it works and why it works. I know in some people it does. I know that the placebo response is playing a role in this, but we don't know how much yet of a role, and we're going to try to get that figured out. I'll share with you also, you brought up Chinese medicine. I didn't show you all of the treatments available for low back pain. Nick mentioned yoga in his discussion. I didn't mention yoga. Yoga's been very effective. There's a large number of other therapies. And for people who may be seeing this on the video, who are practitioners, I acknowledge lots and lots of other ways of approaching this. I've provided you a sample tonight. Other questions? Yes?
I had a question there. Is that an involved procedure there with the implant of the nerve stimulator? If you have pain in the low back or in the cervical area there, that kind of, I guess, overrides the pain? Because I have a TENS unit. I know when I turn it on there, it actually nullifies the pain a little bit.
Yeah.
The only drawback with this is that the battery goes out, the electrodes begin to slip. I was thinking about actually getting an implant.
Yeah.
Obviously, it's like a pacemaker. Maybe be a little bit more efficient that way.
So the question is about spinal cord stimulation. The gentleman says that he's got a TENS unit. It's has a little battery pack and a stimulator that has pads that you put on the back or up on the neck that causes this buzzing sensation. The downside with a TENS unit is that the batteries can die. So he's thinking of getting a spinal cord stimulator. The data on spinal cord stimulation for back pain appears to be getting better, particularly with the improvement in the technologies. I view spinal cord stimulation, while an appropriate treatment, it is well beyond the conservative approaches. And so I recommend to people, try the simple stuff first. Try the self-management and the education. Try a lot of these other approaches before you get to spinal cord stimulation. While it can work and it can provide benefit, be aware that there are some downsides with it. You now have for the rest of your life a piece of implantable technology that can become infected. And there is a risk of that. The leads themselves can move. So the message that you're getting from me is that when you have these discussions, make sure that you're weighing the risk and the benefits with each of these therapies. Yes, there can be some incredible benefit with it, and yes, there can be some untoward consequences, and you need to work together with your physician to find out what's best for you. Other questions? Yes, ma'am.
With regard to peripheral neuropathy, which I've been told is connected to spinal stenosis.
Okay.
At times there is no pain to speak of, but at other times there is. And is that kind of pain can be treated in any way because it's not constant.
Yeah. So the question is about peripheral neuropathy, and you also drew a connection to spinal stenosis. I'll share with you that those are actually two separate concepts. So peripheral neuropathy involves some degree of injury, some irritation, injury out in the peripheral nerve, out here in the legs or in the arms and the hands. And that's something that is very common in this country. It's most common as a consequence of diabetes. It's probably the most common reason. There are also other causes too. Hypothyroid, low thyroid level can be associated with it. Exposure to chemicals and other toxins can cause it. And there's also just unknown reasons why you could get a peripheral neuropathy. You end up with burning, terrible, lancinating pain out here in the feet and the legs. Spinal stenosis is a different condition. What happens with spinal stenosis is that you get an encroachment in your, where your spinal cord is coming down through the canal. It starts to get closed off, and the nerve roots get pinched, if you will. What you often find with spinal stenosis is this phenomenon we call neurogenic claudication. It's this burning pain that often occurs in your thighs that's particularly worse when you walk. When you're walking around, it gets worse and worse. And then when you slow down, it often gets better. You'll often can see the people who have bad spinal stenosis because they're often the people that are in the grocery store that are really hunched over on the grocery cart and they walk like this, because it turns out that in this bent forward position, it opens up the spinal canal and it puts less pressure. So they like to stay in this position. They don't like to don't like to be up like this or back. But those are really two separate situations, and you want to make sure that you see a physician to get a good diagnosis. And particularly, peripheral neuropathies, there are things that can be done to help you. Yes?
I'd like you to compare and contrast, if you would, epidural injections versus, I think you said it was a lidocaine injection. Epidural seems to have a time frame on it that can last for a few months to many months. And if I understood it correctly, the lidocaine injection, if I use the phrase correctly, may have a more permanent effect?
Well, I understand the question was to compare and contrast an epidural injection with a lidocaine injection. And I'm going to, if I can, put it back to you and ask you to restate it insofar as a lidocaine is just a local anesthetic. It's the drug that it is a drug that we can inject. We can inject that into the epidural space as part of an epidural. We can also put that into a muscle, and that becomes a trigger point. So in one case, you're talking about the procedure, and in the other case, you're talking about the drug. Was there a particular compare and contrasting of the epidural procedure against a different procedure?
I perhaps misunderstood, for which I apologize.
No, I may not have been clear, and I know, and I want to also share with you. Despite my wanting to make sure that I'm talking clearly, I sometimes fall into jargon. All physicians, we all do this.
I thought there was one injection that kind of burned the nerve.
I gotcha. So the question is, you thought there was an injection that burns the nerve. Yes, that's a radiofrequency rhizotomy.
Oh, that's what I was going to say.
That's right. I did tell you there was jargon in there. I promised you there would be some jargon. Okay. They're really used for different purposes. The epidural, while people have used that for back pain and neck pain, it hasn't been shown to work as effectively for axial spine pain. It tends to be better for the pain that shoots down your legs. The rhizotomy is burning the nerve that's going to the facet joints, the joints that allow you, remember to do this so you don't walk around like you've got a pole, And what we first do are diagnostic blocks with a local anesthetic like lidocaine and a little steroid. And if you get benefit from that, if it's really allowing you to move fluidly, like we've had patients that say, wow, I haven't been able to do this in months or years, but if it's short lasting, and maybe you get a couple of those and it works great, but it's still short lasting, we might move you on and do that burn of the nerve, the radiofrequency rhizotomy. And that will often last, for the people that it works in, that can last for months and longer. And then that gives us time to get them involved doing the things that Dr. Karianis was just showing you, because the key here is to help build up those core muscles, the strength, the flexibility, so that you don't need the procedure done again, so that hopefully the pain doesn't come back. Other questions? Yes.
I'm curious, are you familiar at all with Esther Goclay and her ideas about posture and exercise? And if so, do you have any thoughts?
Sure.
Pass this around.
So,
Just talk into it.
sure, yeah. Oh, that was loud. I do, and I wouldn't say that her concepts are really unique necessarily. They kind of are postural exercises that are known amongst different disciplines, if you will, and with the emphasis of, kind of having better postural awareness and finding movements. There's a lot of overlap with, I would say, and again, not fully versed on her approach per se, but what little I've been exposed to, it's very much sort of drawn from the works of Feldenkrais or Alexander technique, and even just sort of fundamental postural analysis that physical therapists are, sort of familiar with. So a lot of it work draws from many disciplines. So
Some of it just sounds like sort of common sense to me from the little bit that
sure,
I read.
yeah.
Okay.
So it's just about movement exploration, which is a good thing, however you label it.
Yeah. Is it safe to say that a lot of these therapies, they're shared and they're kind of repackaged and given different names?
Exactly. There's a lot of relabeling, if you will.
Yeah. Other questions? I think your hand went up first in the back.
I was told getting an inversion table and hang upside down alleviates.
You hand it to me.
Is that just a temporary fix, or in the long run, if I hang upside down more so than ever,
Right.
is it going to be beneficial?
Yeah, so the question was, in inversion tables and their efficacy, essentially effectiveness. And not a lot of evidence to support them. You can get some short-term symptomatic relief, but most patients find being inverted causes other issues like a lot of blood pressure to the brain, which isn't very comfortable. So it's very short-term. If you get some symptom relief from it, that's great. But I wouldn't view it as a long-term solution or any changing of your anatomy in any ways. It's just a short-term solution. It's a traction, essentially a traction type of technique. And those are typically more, advocated for when people who have, Sean mentioned, people who have radicular pain. Traction, there's, again, low evidence, but some traction can help temporarily relieve symptoms. And the idea being that you progress to more movements and restoring your motion control as being the more long-term approach.
I saw it. Yes.
It's a follow-up question on the procedure that I couldn't pronounce. The epidural with a steroid and lidocaine is short-term, lasting for months or whatever. Then that dissipates and you go on to another injection or a modality. But burning the nerve, to me, is permanent, and there's no recovery from that. Doesn't that have a downside if the nerve is gone?
Yeah, great question. So the gentleman asked a really insightful question that he was talking about some of the short-term benefits from, say, epidurals or even medial branch blocks, but if you burn the nerve, which you do in a medial branch, doesn't that have some downside consequences? It's interesting. Usually, the message that I give people who come to me and say, my doctor wants to cut a nerve or burn a nerve in my body is run away as fast as you can. That the nerves don't want to be mucked with. They don't want to be burned or injured or damaged, because what happens is that they often, when they grow back something called a neuroma, which is this tangled web of nerves, because they often don't know where to grow back, and then you get more pain than when you started. If you've ever heard of a Morton's neuroma in the foot, terrible burning pain. People who get an arm cut off, those nerves severed, often form neuromas. Interestingly, for reasons we don't yet understand, when you burn those medial branches around the spine, they don't form a neuroma. They don't. They do tend to grow back, though. They do tend to grow back. And interestingly, that's why that pain relief isn't permanent with that particular procedure, because it takes some odd number of months for that medial branch nerve to grow back. Now, is there downsides to that procedure beyond the procedural downsides? There are some theoretical downsides that maybe by burning that you're losing some proprioception, some position sense that those nerves are also carrying, and that loss of position sense may have some downside. I know Dr. Karianis has got some interest in it. Do you have anything you want to add to that point?
No, I'm interested in studying that. I had, again, that same theory that your joint position sense could potentially be impaired, but I don't think we have enough data to support that yet.
I don't think we do have enough data, and it's right now entirely theoretical, and we haven't seen, to date, long-term consequences of that particular procedure. Yes?
This 400-person study that you mentioned?
Yes.
Can you get on the list now?
That 400, yes, you can. That 400-person study. Thank you. Thank you very much. If you go to the website, it's Snapple, snapl.stanford.edu. That's our lab website. Snapple stands for the Stanford Systems Neuroscience and Pain Lab, or Snapple, where we study the best things on earth that hurt. It's amazing. I know it's amazing to me the soft drink company lets me get away with that. But snapple.stanford.edu, and it has all information about the studies that we do and about how to sign up as a participant. And we do reimburse well, and we're hopeful that we can learn a lot from this research. Thank you. Other questions?
What's the difference between the fentanyl patch as far as actually applying it on your skin compared to, I think there's an intravenous way of doing it as well?
The question is, what's the difference between a fentanyl patch, which is applying it topically on the skin, and it's a long-term drug delivery system, versus intravenous? The thing you have to distinguish with a fentanyl patch, because sometimes people get a fentanyl patch confused with a lidoderm or lidocaine patch. A lidoderm patch is just releasing the medication locally. It's just staying at the local site. A fentanyl patch is a drug delivery system. It is not that much different than if you took a long-lasting pill orally. The problem is you can't take fentanyl as a long-lasting version. So the patch releases it, exudes it into your system over a period of 3 days. So it gives you a long-lasting, continuous supply of medication. The intravenous form of fentanyl, we don't really use for chronic conditions. We use that mostly for short-term procedures, such as anesthesiologists will use that in the operating room. Do I use much of the fentanyl patch for chronic low back pain or chronic pain? No, I don't. This is where you'll find some variability amongst physicians. I have a hard time titrating or adjusting it because it only comes in these fixed doses. And I find that there's often better ways that I can work with to help manage people's pain. But it is an option for some people. Other questions? Yes?
Have there been any studies on release of pain from marijuana?
Is there any studies on relief of pain from marijuana? Thank you for asking me a simple one. One that's not controversial and highly politically charged. Here, as we are in the great state of California in the Bay Area, there are studies on marijuana and pain. Most of the studies have been related to short-term relief of acute pain with marijuana, some showing benefit for neuropathic pain as well. Turns out that the neurotransmitter, the active transmitter in the brain, or these cannabinoid receptors, they're highly prevalent throughout the brain. And we know they play a role in analgesia, and they also play a role in many other functions. And there is intriguing research in the area of these cannabinoids. We don't, at Stanford, tend to prescribe medical marijuana. We don't prescribe it. One of the problems that you find with marijuana is it's not only hitting the cannabinoid receptors, but it's probably got 1,000 kajillion other receptors that it's hitting too that we can't really control and understand. And so, we tend to try to find other therapies that work, but I'm optimistic, I'm hopeful that someday with continued research in this field that we will be able to develop potentially peripheral cannabinoid agents that can work out here in the body to reduce nociception without causing some of the potential consequences long term. Other questions? Other thoughts? All right, thank you so much again for coming out and spending the time with us tonight. Really appreciate it, and you folks have a wonderful evening. And thanks to Nora for putting this on and her staff. Great job. Give a shout out to her.